Assalamu alaikum from California here. I had received some questions in the past which I was not able to answer because I was traveling a lot and I was very busy at the practice. So I'm going to answer some of those questions now. Number one question was about dentin sensitivity and the sealing of the dentin. So we'll discuss that in part meal or piecemeal. In preparation of the tooth, I would recommend that you do use water. You don't have to use tremendous amounts of water as long as there is a spray on the tooth to keep it cool and to ensure that there's no fracture lines resulting into the enamel or overheating the dentin when the treatment is being done. Occasionally, I would go ahead and slow down the handpiece completely at the very lowest possible substall speed to polish the crown margins, but those margins are being polished into the enamel, and at that time I would turn the water off. But the speed is very, very low, and I'm only using an end burnishing, end cutting or end polishing burr, which does not have the cutting edge on the side. Hence, as I'm doing the treatment, I'm just polishing the margin, and that would not cause a sensitivity of the dentin to exacerbate. In case you're using high-speed handpiece with no water, it would create a lot of heat, and then you actually do not have dentin's hypersensitivity. You're causing reversible, or at worst case scenario, irreversible pulpitis. So the handpiece needs to be running at high speed, and if you're running it at high speed, you want to make sure that there's a copious amount of water. If you do not want water there, then the handpiece needs to be at very, very slow speed, and it should be used only to polish the margins of the crown preparation. Now, once you're done with the preparation, it comes time, let's say for using if you're doing a restoration of composite resin, I would go ahead and wash the tooth. I would acid etch it. In acid etching it also, you got to be very careful. Do not over etch the dentin. We also know that hydrophosphoric acid or orthophosphoric acid is being used for etching of tooth structure. But we have different time frames of etching of the tooth structure. Enamel needs about 20 seconds. Dentin needs only 15 seconds of 37% phosphoric acid. Cementum, on the other hand, only needs 7 to 10 seconds. So how do you get those times in? What I recommend doing, and that's what I do, is I use a syringe to deliver the etchant. With a fine tip, I would apply the etchant to the enamel first. Approximately 5 seconds later, you apply it to the dentin. Another 5 seconds later, I would apply it to any cementum. It might be subgingival in especially class 5 preps, or when it comes time to cement a crown to a tooth which has been prepped for either zirconia, PFM, or all ceramic restoration. And then I would wash them all. Before I start washing, just a word of caution: suction off the etchant. Because a lot of times when you use a high water and air spray onto the tooth that you have the etchant on, you're going to blow the etchant all over the mouth, and it's going to give the patient very bad taste at the least, or cause chemical burn to the soft tissue. So I would take the high speed suction, put it on the tooth, and section away the etchant first quickly, and then wash away the rest of it, whichever one is a little bit left. I've made little notes on the side to make sure that I do answer your questions. Now, once you have washed it, it is very important to dry the dentin, but not to desiccate it. Majority of the latest generation adhesives actually do not need complete drying. So if you want to dry and not let a pool of water sit there, lightly blow the water on it so the dentin is still moist. What dryness does, it pulls the fluid out of the dental tubules, and then it gets sucked back in, and that would cause a gradient difference in the dental tubules, hence causing undue pressure onto the fibers in the dental tubules. So I would pay emphasis in drying it, but not desiccating it. And once you have applied the adhesive cement onto the tooth structure, rub it in nicely. Let it flow. Most of them are very thin in their texture or in their fluidity. Let it sit there for about 5 seconds or so it gets absorbed. Most of the adhesives have some kind of solvent. Acetone is one of the most primary solvent that is used. So as I am curing the adhesive, before that I would blow a little bit of air onto the tooth structure to evaporate the adhesive acetone from the tooth structure, but don't blow too hard. Secondly, I would make sure that in any corners we do not have pooling of adhesive. If you see it, then go ahead and take the brush and clear away that pool of adhesive at the corners to make sure that you have good strength of composite when it goes into that corner. I would apply the layer, I would cure it, and then I would apply a second layer and I would cure it. If you have dental adhesives that actually have HEMA in them, then that itself would cause the dentin to be sealed and reduce the sensitivity. Using this technique, I do not know in the last maybe 10 years or so I have had any complaints of sensitivity because of the composites I've done or the crown cementations I have done. It's a very safe alternative and a safe way to do it. 2 or 3 layers of adhesives, very thin layers, and cured after you evaporate the solvent from it would really help you a lot. Now, when you start building up the composite, what I do recommend is you build up one cusp at a time. And let's say you're doing a mesiolingual cusp on a lower tooth. I would build up the mesiolingual cusp in a triangular fashion. Once it is being built, I would cure it from the mesiolingual aspect, not from the occlusal, not from the facial. As you're curing it, the composite tends to shrink, polymerization shrinkage. It would happen towards the cusp and no stress would be built into the cusp itself. I would build each individual cusp individually and cure it from the perspective angle. And by the time I'm done building each individual cusp and also the marginal ridges, do remember the marginal ridges have facial marginal ridge aspect and the lingual marginal ridge aspect with the sulus wear and embrasure in between. So even the marginal ridges I build them individually. So there's no stress into them. And then you get the proper occlusion and you check the occlusion and you cure it finally on the occlusion. Somebody asked the question that how do you take care of the oxygen inhibitive layer up on top, the top layer of the composite? Once I'm almost done with my composite buildup, I would go ahead and check the occlusion to make sure that we are not in hyperocclusion. I would clean the surface again with hydrogen peroxide. You could even acid etch it again, the top part of the composite you have done, and I would apply a layer of composite resin adhesive on top. I would cure it. Then I would apply a second layer of it. I would cure it. Now what happens is the top layer of the adhesive that I've applied technically has not cured because it's inhibited by oxygen presence in the air. But the layer of composite adhesive below it is cured and the composite below the layer is cured. Now why would I want to apply adhesive onto the occlusal surface or the facial surface of a composite I just did? A lot of time I do notice there could be porosity on the surface, especially where the margin meets the composite. And this resin, adhesive resin, gets into the micro porosity and seals the surface very nicely and you'll get very satisfactory results. Now, as far as cementations are concerned, of zirconia compared to PFM, compared to all ceramic restoration, I'll make another video and discuss that because it itself calls upon a lot of different aspects of cementation, the physiology, the biochemistry, the chemistry itself, and what affinity do each one of these materials have, and how we have to be careful in curing them, how we have to be careful in selecting our materials, and how to get it done right. If you have any questions or comments about this, please feel free to message me out. My email address is drqdds, that is drqdds@gmail.com. My WhatsApp number is +9232144613777. My old number, which is still in use but I don't like to use it too much, is +1-714-244-9239. You're welcome to ask any question that I might be able to help you with or pass any comments to me. Thank you.